Dr. Olachi Mezu-Ndubuisi, who is an associate professor of pediatrics and ophthalmology with tenure at the University of Rochester, New York. Dr. Mezu-Ndubuisi's dual expertise as a licensed optometrist and neonatologist has enabled her to develop a unique research niche studying retinopathy of prematurity and the effects of oxidative stress on developing organs in both lab and clinical research. Dr. Mezu-Ndubuisi has over 28 academic research publications, including 4 book chapters and a textbook. And as a physician scientist, she participates in humanitarian global health activities with a commitment to an integrated path of research, teaching, and service. Dr. Mezu-Ndubuisi, please come up.
Thank you so much for the kind introduction. Good afternoon, everyone.
Good afternoon.
My name is Dr. Olachi Joy Mezu-Ndubuisi. The title of my talk today is Life Lessons from a Physician Scientist's Journey Using the Eye as a Window to the Body. I'm incredibly honored to be invited to give the annual Auld Memorial lecture in memory of a giant in pediatrics, Dr. Peter A.M. Auld. Dr. Peter A.M. Auld trained in Montreal, Canada and Children's Hospital in Boston prior to making Weill Cornell his academic home from 1962 to 2023. He contributed significantly, as we heard, to the fields of medicine, pediatrics, and neonatology. Dr. Auld's inspiring legacy lives on in all whose lives he has touched, including many who didn't meet him. I have nothing to disclose. During my talk today, we will discuss how I have been fortunate to integrate my clinical work, research, and service as a clinician scientist. We will highlight retinal imaging as a window to understanding systemic disease. We will then review how understanding retinopathy of prematurity, ROP, can help us optimize and integrated care of neonates. Lastly, I will outline positive life lessons along my career path. The first life lesson I will share is love yourself. First, know who you are. Growing up in southeastern Nigeria, our parents instilled in their 10 children a love for learning and a heart of compassion. They made us believe that we could achieve anything we set our minds to. So, believe in who you want to become, the best version of yourself. As a clinician scientist, I love to teach. Critical questions arising from my care of babies direct my clinical and lab research. Likewise, research insights inform my gentle care of babies at the bedside. The COVID-19 pandemic has kind of taught us that we're all connected in our humanity. I am grateful for the opportunity to integrate my research, teaching, and service, both locally and internationally. Investigating the role of oxidative stress on the retina and systemic disease uniquely blends my practice as an optometrist and a neonatologist. We will start by reviewing oxidative stress and ROP pathogenesis. One may ask, how much oxygen is too much? We do not know. Oxygen is a drug. It is a vital element but can be toxic to the body. All biological reactions need energy in the form of ATP that is produced by the mitochondria. Electrons from glycolysis and Krebs cycle are transferred through 4 enzyme complexes in the electron transport chain. The energy released at each complex creates a protein gradient needed to form ATP. Cytochrome C oxidase, the 4th enzyme complex, transfers 4 electrons to oxygen as the final electron acceptor. Oxygen then combines with 4 protons in the surrounding to form 2 molecules of water, and NAD is oxidized in the process. Oxygen has an atomic number of 8, as we remember from chemistry, but is very highly reactive with 2 electrons on the inner shell, and the outer shell has only 6 electrons left, making it unstable because it needs 8 to stay stable. So you can imagine that an excess supply of oxygen can overwhelm the system, and oxygen molecules combine with each other trying to complete that number of 8, and they form superoxide radicals and other free radicals and reactive oxygen species. So how does oxygen exactly affect the premature infant's organs? In utero, there is a low oxygen environment, and so preterm birth into a high oxygen environment overwhelms endogenous antioxidant mechanisms, forming oxygen-free radicals which affect angiogenesis, cell survival, and proliferation. This affects gene expression in tissues and organs, causing DNA oxidation, lipid peroxidation, which can poke holes in the respiratory epithelium, for example, and protein oxidation, which can inactivate surfactant in the lungs. So free radical damage causes intraventricular hemorrhage in the brain, retinopathy or prematurity in the eyes, respiratory distress syndrome in the lungs, and necrotizing enterocolitis or neck in the gut. These are all called neonatal diseases of oxidative stress. On the other hand, prolonged hypoxia can contribute to inflammation, which can exacerbate these conditions. So that's why an integration of care of the preterm infant is so important, where one organ is not prioritized over the other. Whatever you give to your lungs will affect the brain, the retina, the gut, and the kidneys. So how does vision work? Light rays from my favorite flower, a rose, enters the eye through an optically clear medium to refract on the cornea, then the lens, to come to a point focused on the retina, the innermost layer of the eye. But the retina is not a flat tissue. The light rays will go through the 10 layers of the retina to the photoreceptor layer, where it's your rods and cones, which convert the light signal into a photochemical signal that is transmitted through a series of synapses. The photoreceptor cells will synapse to the bipolar cells, which synapse to the ganglion cells, which axons make up the optic nerve fibers that carries the information to the brain to interpret color, depth, form, and the cognitive understanding that, yes, that's a rose flower, but no, you shouldn't eat it. Retinal vessels develop by the process of vasculogenesis, where primordial vascular cords form the superficial retinal plexus, and later by angiogenesis, where vessels form from existing vessels to populate the deep retinal plexus. Retinal vascularization starts in utero from about 16 weeks of gestation from the optic nerve outwards. The nasal retina is vascularized first at 36 weeks and the temporal retina by 40 weeks. Well, prematurity, you can imagine a baby born at 27 weeks gestation. Prematurity would disrupt vessel growth, creating an avascular retinal periphery. So let's talk about the biphasic pathogenesis of ROP. In utero, hypoxia drives angiogenesis in the developing retina. With preterm birth, the infant is now cut off from the placenta and amniotic fluid proteins like growth factors like insulin growth factor 1 or IGF-1 and vascular endothelial growth factor VEGF. The infant is now exposed to a hyperoxic ex-utero environment. The roommate you and I are breathing is hyperoxic for this baby. So hyperoxia now disrupts angiogenesis, exacerbated by the supplemental oxygen that we're giving them for their long immaturity. And this causes oxidative stress, releases free radicals, which injure the retina, leading to ROP. ROP progresses in 2 phases. Phase 1 occurs shortly after birth in high oxygen, which now downregulates VEGF expression, leading to vaso-obliteration. The vessels where forming start to die off, and new vessels do not form. 4 to 6 weeks later, there are now not enough blood vessels in the retina to nourish it. We saw those network of millions of nerve fibers and neurons, and they become hypoxic. And this hypoxia now causes a fluid excess secretion of VEGF, leading to phase 2 ROP, which now is characterized by pathologic neovascularization, bleeding. The blood gets congealed and tugs on the retina, causes fibrosis, and pulls on it, causing retinal detachment. Other risk factors for ROP include inadequate postnatal nutrition. There's always a challenge to provide enough calories for growth for these babies. In addition, they have a deficient antioxidant mechanism and may be prone to infections and inflammation. Another life lesson. Trainees often ask how to know if they will be successful in their career paths. I always tell them, find your passion, purpose, and value. Please repeat after me. Passion.
Passion.
Purpose.
Purpose.
Value.
Value.
Your passion is that which you love to do, such that no one needs to remind you to start, but someone needs to remind you to take a break. That is what you should be doing with your life, and you will excel in it. Purpose is why you do what you do. Having a purpose that seeks the good of others beyond your own personal gain makes life more meaningful. And having premature 1-pound birth weight babies during my first fellowship gave me purpose. Value is the impact you have on yourself and others. Being in an environment where your contributions are appreciated or valued brings out the best in you. We're going to move on to clinical diagnosis and treatment of ROP. ROP exams begin in the NICU at about 31 weeks postmenstrual age or PMA, or 4 to 6 weeks after birth, whichever comes later. Babies weighing less than 1,500 grams are screened, but larger babies can be screened if they're critically ill with prolonged use of oxygen or at the request of your friendly neighborhood neonatologist. ROP is clinically classified by zones and stages. Zones refer to the area of the optic disc that is vascularized in relation to the optic disc. Zone 1 is a concentric circle centered around the optic disc and 2 disc diameters temporal to the macula. You can see that dot right there. The macula is the point of sharpest vision and color vision. You do not want any abnormal vascularization in zone 1, as its presence requires treatment and the baby can be centrally blind. Zone 2 is the concentric circle right there in red around zone 1, extending from zone 1 to the nasal peripheral retina. You can imagine your nose right there. Zone 3 is the remaining crescent-shaped area on the temporal side in red. The extent of ROP can be defined by clock hours of eye circumference affected. 9 clock hours would be 270 degrees. Stages refer to the vessel appearance at the vascular-avascular interface. In stage 1, instead of a fine blending of the vessels into the background, if you look at that edge, the ophthalmologist using the BIO would note a hypothetical sharp demarcation line at the vascular-avascular interface, such that you can see where the vessels grow and stop, and the rest of the avascular retina where there are no more vessels. And if you look at the schematic right there, it gives us another perspective of this hypothetical demarcation line. Stage 2 is a fibrovascular ridge forming at that vascular-avascular interface. You can imagine that you would feel a hump if you run your fingers or hand over it. It's a sign of proliferative activity happening in the retina. Stage 3 is pathologic neovascularization or extraretinal fibrovascular proliferation that forms right at that ridge. You can see from the schematic, some of these vessels are very fragile because they've lost their connection to the parent blood vessel, so they're very fragile and bleed easily. So that is a sign of severe ROP. Plus disease or engorgement or tortuosity of the vessels around the optic disc is a powerful indicator of severe ROP and mandates treatment within 48 to 72 hours. Stage 4 would be partial retinal detachment, and stage 5 will be total retinal detachment, where the retina is pulled away from the RPE layer beneath it and cut off from blood supply, and the baby is totally blind. Laser photocoagulation and intravitreal anti-VEGF drugs are both the current standard of care for ROP. These are photos and corresponding angiograms that are comparing laser and intravitreal bevacizumab injection in preemies with stage 3 zone 1 ROP. Bevacizumab is a monoclonal antibody against VEGF that was FDA approved for lung cancer and metastatic colorectal cancer and breast cancer, and used off-label for ROP treatment. Image A there is before laser, and image B is after laser, where you can see a full thickness destruction of peripheral retina with the underlying choroid visible. Image C is before intravitreal bevacizumab therapy, and image D shows continued peripheral retinal vascularization beyond that vascular-avascular interface after injections. However, we can see that worked really nicely. The vessels kept growing back, but there is a higher risk of ROP recurrence with bevacizumab injections or any anti-VEGF injections up to 70 weeks PMA. And so these infants need a much longer follow-up. Other concerns of anti-VEGF therapy are they are systemically absorbed, even though they're injected in the eye, and they cause PEM blocking of VEGF in organs that need VEGF for growth of their vessels. Another life lesson. You become what you think, so think positively. Your thoughts affect your emotions, your words, and your actions. Your actions affect your life experiences. 7 days after having my micropremies, my son, Obiola, passed away. And my daughter, Olarose, stayed 3 months in the NICU. After a few months, I took a break from fellowship to focus on caring for her. After working in the community hospital NICU as a pediatrician for 2 years, I decided I wanted to complete my fellowship, and I moved to a new state. It felt like I was starting life all over again. I woke up each morning saying, it's going to be a great day. I can do this. Disciplining my thoughts positively changed my life. The current concerns of ROP treatment include the increase in birth of preterm infants with advanced technology in perinatal and neonatal care, but then there are a limited number of ophthalmologists and the stress of eye exams on the babies. I say that dilating drops make grown men cry. When the babies are being examined, their heart rates drop, oxygen saturation drops, everyone starts panicking, and they require intervention. And also, there is a lack of a standardized objective diagnosis for ROP. So you can see from what I said is quite subjective. So diagnosing a stage 2 in zone 2 rather than a stage 3 in zone 1, though rare, could delay treatment. Finally, current ROP treatments have adverse effects like we showed. So, during my second fellowship in 2011, my initial hypothesis that the oxygen we give to babies is given through their lungs through invasive and non-invasive devices, but the effect we're seeing in the retina. So I believe that oxygen would affect not just vessel formation in the retina, but entire retinal tissue. So I believe that ROP affects retinal vascularization, structure, and function, and this could be studied in vivo without killing the mouse. I had no prior training in bench research, never touched a mouse before. There was no one in my institution studying ROP to teach me flat mounts, and watching YouTube videos didn't help. So I asked the question, why can I not look directly into the eye of a mouse to visualize retinal blood vessels like I would when I'm examining a baby? I was told that it was not possible because at the time ROP studied about P17, the eyes of the mice are fused, but I wanted to find out. So I learned how to handle mice, borrowed the mice from a pulmonary researcher, and would take it to the ophthalmology department where a PhD researcher was studying oxygen tension in rats. And I asked if I could use her device for my mice. So we would anesthetize the mice, pry open their eyes with tape. They were open. Sometimes we needed to make a little cut. Then injected fluorescein, and boom, we could visualize the retinal vessels. The newborn mouse is equivalent in gestational maturity to a 24-week-old infant, and both undergo postnatal retinal development. For in vivo imaging, we modified the existing mouse model of oxygen-induced retinopathy, OIR, by Dr. Lewis Smith. The newborn mice were separated into two groups. One group was raised in room air that line with 21%, and the other group was raised in 77% oxygen at postnatal day P7 to P12 to simulate vaso-obliteration, and then they return to room air at P12. From then on, they would simulate relative hypoxia because room air is relatively more hypoxic than the high oxygen they were in. First, the mice were anesthetized, their pupils dilated, and fluorescein was injected intraperitoneally to visualize the vessels. And we started fluorescein angiography, or FA, within 1 to 2 minutes. So these are P19 FA images. The earliest I've imaged is P16. In these images, you can see the arteries are highlighted in red and the veins by the blue arrow. Arteries have a bifurcation, as you can see. They'll bifurcate a little bit unevenly. And the veins have tiny little venues that are draining into them from the retinal tissue. One could clearly see a difference between the fully vascularized capillary network and normal caliber vessels of the room air mice. The OIR mice have avascular retinal peripheries, and then also they have tortuous arteries, dilated veins, and sometimes AV shunts develop between the artery and the vein as a sign of hypoxia in the underlying tissue. OIR mice also show these features of plus disease that are quite similar to what we see in the retinas of infants with ROP. I went on to study these FA changes in my first job throughout the developmental maturity of the mouse, just to see how long these changes take. To quantify the vascular features that I was seeing, I developed a customized MATLAB program with bioinformatic experts that I've now made publicly available at quantbv.com. This software has been used by other researchers for vascular quantitation beyond ROP. I was able to group the changes I was seeing in phases that I called early phase, from P16 to P20. And here you see avascularity in the capillaries, dilated veins in the bottom line of the OIR mice, and tortuous arteries compared to room mice in every age. But there was no significant difference between individual A's in this phase. Mid-phase from P23 to P27 showed some recovery of these abnormal features, and the late phase from P30 to P34 showed full peripheral vascular coverage, normal vein width, but persistent arterial tortuosity. You can see there's full coverage, but these vessels are still quite tortuous. So we went ahead and used the QuantBV to quantify the vascular features, and then we discovered that the percent retinal vascular area showed the greatest difference between OIR in the shaded bar and the room air mice in the early phase. The retinal vein width was wider in OIR mice in early phase 2. However, retinal arterial tortuosity was markedly increased in OIR mice in each phase studied. So arterial tortuosity could be a more reliable marker of OIR severity or recovery. I then designated the mature phase to comprise the adult mice older than P35, and actually how that came about, we sent this paper for publication and the reviewers came back, how do you know these mice haven't recovered? Because you're just imaging neonatal mice. So you need to look at them past age of sexual maturity. So we did. The changes were still there. So a closer look at the capillary network using in vivo imaging shows that the neovascular buds can see this fluorescent dots right here in the room air mice, a sign of angiogenic activity, was completely and clearly absent in the OIR mice. This differs from existing literature that reports that OIR mice recover from oxygen exposure between P21 and P25, but our in vivo imaging shows that despite full retinal vascular coverage or revascularization in this mice, there is permanently reduced angiogenic activity from just 5 days of oxygen exposure. I wondered why and what this could mean for premature infants that are exposed to very high FiO2 for weeks and months. Using one age to represent each phase, we next explored the effect of OIR on retinal structure with in vivo spectral domain optical coherence tomography, SDOCT, following the FA. We showed that OIR mice had total retinal thickness that was reduced, the arrow in red, compared to the room air mice. However, the outer retinas of OIR and room air mice had similar thickness. Rather, it was the inner retinas of OR mice that were thinner. We then decided to look at function with focal electroretinogram, ERG, and we looked at a region of interest in that red circle. There was 2 disc diameters from the optic nerve, and there was no difference in the A wave generated from the outer retina, time to get to the A wave, and no difference between both groups from the B wave from the inner retina. But the time to B wave we saw was prolonged in OR mice, and this indicates an abnormality in post-receptor signal. It could be that the inner retina appeared to have a delayed reception of signals from the outer retina, or a delay in generation of signals within the inner retina. We now began to wonder if capillary atresia that we were seeing in those FA images was related to the inner retinal thinning and dysfunction. So we decided to take a closer look at a slice of retinal histology to study the cellular content of the retinal layers and see how the retinal blood vessels were connected with the neurons and glia cells. You know that retinal microglia and macroglia provide a supporting network for the retinal neurons, but they become activated during injury or stress. But how long glia activation lasts and what its effects are in retinas and ROP is relatively unknown. So we decided to find out. We performed immunohistochemistry on the retinal cross-sections after in vivo image we extracted the retinas, and then found that there was more GFAP positive astrocytes in the nerve fiber layer of the OR mice. You can see this layer here, just below the inner limited membrane compared to the room air mice. The Mueller cells span the entire retinal cross-section from the inner limited membrane right there to the outer limited membrane. It was interesting to note that there was no GFAP positive staining of the Mueller cells and the side that has room air mice in every age, but there was GFAP staining in the OIR group persisting until P47 in adult OIR mice. We now started to look at the synaptic connections to see what was going on. In OIR mice, we found malaligned ectopic synapses between the photoreceptor cells stained green with postsynaptic density protein PSD95 and the rod bipolar cells stained red with protein kinase C, PKC alpha, while the room air mice had uniformly well opposed and aligned synapses. The white arrowheads there show that the ectopic synapses were extending beyond the outer plexiform layer to the outer nuclear layer where you see the cell bodies of the photoreceptor cells. Another life lesson. We all seek peace in life. Life's path is never straight. However, in my life, I found that every twist and turn was either a lesson, a blessing, or both. Moving to a new academic institution, one of my collaborators was unable to continue producing microparticles needed for my NIH career development grant, and I was sort of stuck. What do I do? And there was no one in my new institution that could help me. I decided that I was going to produce these microparticles in my lab, and it seemed impossible, but this closed door became a new direction. We not only produce microparticles, we're able to achieve even the smallest size nanoparticles. So peace comes from trusting that all things work together for your good. Live in the present and take actions of things that are within your control. Despite current therapies, ROP remains the leading cause of childhood blindness worldwide. This raises concern of insufficient treatment as laser and anti-VEGF therapies do not treat inflammation from oxidative stress. VEGF is actually a very complex protein with several isoforms from A to E. VEGF A is predominant in the eye, and it has 2 splice variants, the pro-angiogenic VEGF A165 small a and anti-angiogenic VEGF A165 little b based on splicing at exon 8. So, seeking a non-toxic therapy for ROP, we decided to explore advanced drug toxicity, drug therapy to kind of limit toxicity, and alternate ROP mechanisms such as specific targeting of these VEGF isoforms and treating inflammation that was previously untreated in RP. So in my lab, we fabricated nanoparticles using polylacticoglycolic acid, PLGA. PLGA is an FDA-approved, biocompatible, biodegradable, and non-toxic polymer that allows sustained release. So we mix PLGA and polyvinyl alcohol, PVA, dropwise. Then the solution was sonicated, centrifuged, and lyophilized for about 48 to 72 hours at minus 50 degrees. Next, we incorporated the bevacizumab into the nanosphere using a modified double emulsion solvent evaporation technique. Figures A to D are scanning electron microscope images, SEM, that show that we achieve spherically shaped nanoparticles with sizes ranging from 100 to about 500 nanometers. Figure C shows a burst release of bevacizumab within that PLGA nanoparticle. And figure E is a transmission electron microscopy TEM image that shows that bevacizumab is contained within the nanoparticle. You can see that shaded area right there. We optimized nanoparticle fabrication in 2 experiments by varying the solvent that we use and the drug to polymer ratio. So figure F is a drug release profile showing the burst release of 31% of bevacizumab by 72 hours in experiment 1 compared to 80% in experiment 2. After inducing OIR, we now inject the bevacizumab loaded or empty nanoparticles at P13 intravitreally into just the right eyes of the pups. So there were 6 pups in the cage, so 3 got right eyes injected with beva, and the other 3 got empty nanoparticles as a treatment control. If you look at the P20 FA images, the red arrows point to the arteries, the blue to the veins, and the orange to the avascular areas. The beva right eyes had less vein dilation, less arterial tortuosity, and less avascular capillary network compared to the contralateral beva left eye of the same mouse. The untreated beva left eye looked similar to the retinas of the empty PLGA right eye and the contralateral PLGA left eye of that same mouse. So, bevacizumab nanoparticles did not cross over to the contralateral eye. Therefore, the pro-angiogenic VEGF A165 little a revascularized vaso-obliterated areas following OIR and could be a potential earlier treatment for ROP. Sustained release reduces the need for repeat dosing that can happen with anti-VEGF therapies, and this avoids undesired systemic toxicity. We are very excited about our nanoparticle technology and that we can apply it now topically, orally, and through IV to deliver any drugs to babies or adults for a wide range of conditions beyond ROP. Using CRISPR-Cas9 technology, we knocked out interleukin-4 receptor alpha, L4RA, in wild-type black 6 mice to study the role of anti-inflammatory cytokine receptor, interleukin-4 receptor alpha. L4RA knockout mice that were exposed to OIR on that side appeared more avascular, but quantification did not show a significant difference in retinal avascular area, vasotortuosity, or width compared to the BL6 OIR mice across. However, the L4RA knockout mice, this one, that were raised in rumen had more dilated retinal veins and a tortuous collateral vessel shown in the white arrow that was not visible in the BL6 rumen. So this sort of suggests that the anti-inflammatory L4 receptor alpha is important in developmental angiogenesis. We're now currently exploring the mechanisms of action of L4 receptor alpha in OIR retina. Trying to bring it back home. All blood vessels in the body are connected, and endopas and arteries and veins in our eye and the retina. So I believe that retinal imaging is very underutilized as a biomarker for systemic disease in the brain, lungs, gut, kidneys, and all organs. So in my research, I have correlated retinal vascular injury to acute lung injury and kidney injury. So after in vivo imaging, I still extracted the retinas, the lungs, and kidneys from these mice. And we see that Romare mice, the line on the top, showed normal retinal, lung, and kidney architecture, while the OIR mice showed signs of inflammation with underinflated alveoli, thickened epithelia that had inflammatory cells invading them, and pulmonary vascular congestion, while the kidneys of OIR mice showed vascular engorgement, glomerular thickening, and renal tubular infiltration. All this from the same level of oxygen that has caused retinal damage in the mice, similar to ROP. The lungs of mice were fluid-filled in these images, and this is from eating the same dried chow that the Romaine-raised mice were eating, but the OIR mice were fluid-filled. So I believe the solution to a damaged and wet lung from hyperoxia in neonates is not more oxygen and fluids, but less, to allow the lungs to heal. Hypoxia ischemic encephalopathy, HIE, from perinatal asphyxia leads to long-term visual disabilities in infants, but HIE-related retinal vascular injury has not been characterized. So I collaborated with an HIE researcher in 2018 to induce HIE by ligating the carotid artery of the right eyes of mice at P9, followed by hypoxia exposure. Then we did in vivo imaging with FA in my lab, and we showed that the naive, untreated mice had normal retinal vessels, but the HIE mice showed acute and chronic signs of ischemia in the ipsilateral eye with dilated retinal arteries and veins and a shortened collateral vessel shown by the yellow arrow. So, putting it all together now. Insights gained from in vivo OIR studies suggest that neonatal care should be aligned with the biphasic pathogenesis of ROP and also be systemically integrated where the effect of every intervention on all organs is considered. We do not sacrifice the retina to save the lungs or vice versa. In utero, the low oxygen tension there causes physiologic hypoxia. We remember that the PO2 in the womb is about 20 to 35 millimeters of mercury, right? And the umbilical vein saturations are the most, 50 to 70% SATs that the baby is receiving in utero. But the baby is very happy because this hypoxia upregulates VEGF to stimulate blood vessel development in the retina, brain, lungs, kidneys, and other fetal organs. So, following birth, in the canalicular stage of lung development, the retina also is incompletely vascularized, and these preterm babies are exposed to a sudden increase in oxygen tension with a PO2 in inspired air of about 100 millimeters of mercury. So room air, 21%, is already hyperoxic. But this baby that was getting what? SATs of 50. So why do we expect the baby to be SAT 100? With supplemental oxygen. So hyperoxia downregulates VEGF and arrests blood vessel development in the retina, in the lungs, in the brain, in the kidneys. So right at birth, the primary goal of care is to promote angiogenesis in all organs by allowing a smooth extraurinary transition of oxygen tension. Let the oxygen saturations rise slowly from the 50 to 70% in utero to about 86 to about 90% ex utero. This reduces the risk of ROP, RDS, and prevents the development of phase 1 ROP, which is vasoobliteration that happens on high oxygen. Then, 4 to 6 weeks after birth, as the baby's getting adequate nutrition like we do in the NICU, we should inhibit angiogenesis by allowing higher oxygen saturations of about 92 to 96%, never 100%, that's toxicity, to reduce the risk of phase 2 ROP and bronchopulmonary dysplasia or BPD. I also believe that neonatal care can be optimized in both phase 1 and phase 2 ROP by using an integrated approach, including conservative use of fluids to control pulmonary edema, particularly allowing that physiologic contraction of extracellular fluid in the first week of life. Remember, this premature baby's at 90 or so % water. It has to be contracted. The kidney has to get rid of it. And then we should allow that to enable effective gas exchange. Then judicious use of oxygen avoiding extremes of hyperoxia and hypoxia, and then balancing calories to optimize nutrition, especially with early use of protein for calories for lung growth and to increase oncotic pressure, which will pull water out of the lungs into the vasculature and allow resorption of lungs from the fluid and effective gas exchange, because the air that's coming to alveolar wants a direct contact with the blood vessels. So if there's fluid there, protoedema, you create a distance and your gas exchange is less. And what do you need? You now feel you need more oxygen to drive that gradient. But allowing the fluid to resorb will allow that contact, and you'll be using the minimal amount of oxygen to inflate your lungs. Then we want to limit inflammation and infection. So my understanding of the effect of oxidative stress in premature infants led me to publish in 2023 a textbook, Foci, Fluids, Oxygen, Calories, Inflammation, a physiology-based guide to optimize care of babies. And this is with 171 references, clinical case scenarios, and vivid illustrations. I present here also in the book guidelines for biphasic ROP management and oxygen saturation targets in the NICU and for home-going oxygen with case studies. But babies are not one-size-fits-all. Protocols and guidelines should be tailored to meet their real-time individual needs. NICU staff are very passionate and dedicated and quite protective. You will learn that quickly when you try to examine a baby outside care times. We all care and should work together to gently and safely care for our tiniest and most fragile humans. The last life lesson. It took me some time to finally realize that joy was already inside of me. I just didn't get the memo. Joy is a choice and easier to maintain when you choose selfless values like kindness, compassion, integrity. You cannot control what people say or do to you or others. You can only control your own actions, so be consistently kind. Compassion in service is servant leadership, which prioritizes the well-being of those under your care, especially those that are vulnerable. Integrity is doing the right thing at the right time for the right reasons, even when no one is watching, and even if you lose something of value. So choose to maintain your joy. I remind myself each time that my name is Joy. I derive a lot of joy from my global health service through my family's nonprofit, Mezu International Foundation, MIF. Each spring, I participate in a 2-day annual MIF Health and Vision screening in Baltimore, Maryland, where we serve about 150 people in the community who can't afford care. Then in Nigeria, I travel there every summer, and I lead 80+ medical and non-medical professionals in providing free medical and surgical care to over 2,500 men, women, and children. And I travel with a lot of trainees from the United States. I always say that we receive more joy than we actually came to give every single time. And I have conducted a needs assessment study in 2014 to determine the prevalent medical conditions in the community so we can better allocate our resources to serve their needs. We found a 64% prevalence of cataracts in adults over 40 years old. That's the working population. So cataracts is one of the leading causes of preventable blindness worldwide. So we partnered with a Wisconsin-based nonprofit to provide same-day cataract surgeries during the 2016 medical mission. What an amazing gift to the community. I remember this woman crying tears of joy when her eye patch was removed the next day post-op because she saw her 20-year-old daughter for the first time since age 10, and she couldn't recognize this young woman in front of her. Unfortunately, out of the 100 people that were screened for surgery that period, only 10 qualified for surgery due to untreated medical comorbidities like hypertension, glaucoma, diabetes, and severe anemia. So majority of our efforts now have shifted to earlier diagnosis and treatment of these medical conditions that are chronic in the community. I am passionate about mentoring trainees in my lab, in the NICU, and global health, and guiding them along their own career paths through global health research. We design and validate questionnaires and scoring tools that we've published, and they provide sustainable socioeconomic and cultural solutions to the real-life problems in the community in Nigeria. We get IRB approval from the collaborating local institutions who send like dozens of their own medical and optometry students to help us serve these thousands in the community. And it's just a wonderful exchange of knowledge and camaraderie between the US students and the Nigerian students. So the students that I work with have first authored 6 publications, have given 30 national presentations, and obtained 11 grants based on this research. In my lab, most trainees come with no prior research knowledge or never even touched mice before, like when I started, but they attain proficiency in a very short time with dedicated care, and they always amaze me with their innovation and dedication. I strive to ensure that the lab is a safe space for everyone, and I let my lab staff know that I care about their well-being and their career goals beyond their science tasks they have in the lab. We're almost done. In summary, we have learned that oxygen is vital, but can be toxic and should be used judiciously. Our in vivo retinal imaging has expanded the ROP phenotype beyond abnormal vascularization to show long-term abnormalities in structure and function. We discuss how nanoparticles produced in my lab could help improve efficacy and limit systemic toxicity of ROP treatment and be possibly useful in other treatments. We also reviewed how understanding ROP's biphasic pathogenesis can help optimize neonatal care by allowing gentle extrauterine transition in oxygen tension and systemically integrating the care of all organs where one organ is not prioritized over the other. Finally, I shared life lessons on how to love yourself, how self-love guides your passion, your purpose, and value, how disciplining your thoughts to stay present brings peace, and choosing compassionate values brings joy. Every baby has a potential for greatness. Born weighing 470 grams, my daughter, self-extubated at 10 days of life. At 14 years of age, she was diagnosed with severe, painful scoliosis needing surgery, and she used art, poetry, and music to vividly depict her pain and also the beauty she found in spite of it. This is a line from one of her poems. It reads, "For when we surround ourselves with luminous hope, despite the darkness of the unknown, our path becomes clear." Her poetry on scoliosis won her the title of the 2024 to 2025 New York State Youth Poet Laureate. In the audience today, Ola Rose is 19 years old. She's a rising sophomore in college in the BSMD program and hopes to be a neonatologist to care for premature babies like herself. I am so grateful for the opportunity to continue to do what I do for as long as I can. I am thankful for the support from the NIH, as long as I have it, institutions that I have worked in, my incredible lab staff that are like family over the years, mentors that believed in me and exposed their time and resources for me, and my loving family. Thank you all for being here today. You are amazing, and there is no one else like you on earth. Continue striving to be your best self. Be curious, dream big, be kind, and just do it.
This lecture in her husband's honor.
Thank you so much. Thank you for a great speech in honor of my husband and myself. And I wish you all the best in your journey.
Thank you so much.